So next we have a talk from Dr. John Woolley, who's a GP and clinical lead at See the Signs, and he's going to tell us about ambition to action, building the system to end cervical cancer.
Brill, thank you very much. Hope everybody can hear me okay. God, that picture is really big, isn't it? So my name's John Woolley. I'm a GP in the West Midlands, and I've been at See the Signs now for about 9 months as part of our wonderful clinical team. And today I'm going to talk about a topic which has come up quite a few times, actually, partly through some of the panel discussions and some of the other talks, but also through conversations that we've had with people downstairs, and that is cervical cancer. We've had... I'm just going to move my head off the screen a second. We've had a few sort of personal stories, really, about contacts with cancer, which have been really poignant. And I'm just going to briefly share mine because it's highly relevant to cervical cancer. So my story's sort of 5 years ago, so just before COVID, actually, so maybe a little bit longer. And that was in the days when our sort of consultation lists were filled with untriaged patients, and you just have a great big list, and halfway through the morning you'd be half an hour, 40 minutes behind, and you'd just be in the flow. And I remember vividly, I'm going to call her Gemma for the purposes of this, but I remember looking at my next patient, and in the booking notes it said query miscarriage, question miscarriage. I looked through our notes, nothing. It was clear from the address that she was part of a Roma community that had moved to the area a few years previously, and there was nothing in this person's medical records whatsoever. I called her through, and it was really clear from the moment she walked through the door that something wasn't right. She was pale, she was clammy, tears streaming down her face, and as you do when you're running miles behind, you've got to force and make sure that you don't sort of try and rush what was clearly quite a sensitive and challenging situation. After about 6 or 7 minutes, she began to open up to me, and she said that she'd been bleeding quite heavily down below for about 2 months prior to coming to see us. And before that, she'd had symptoms in that region for a good few months before that still. I asked her why she thought that she might be pregnant, and she said, well, that's the only reason why I might be bleeding, surely. When I examined her, I mean, I, being a male GP, haven't seen as many cervixes as maybe some of my female colleagues would see, but it was incredibly abnormal. There was a horrendous lesion there. It was bleeding, even just from me looking, and I admitted her to hospital. She was subsequently diagnosed with advanced cervical cancer, and she died a few months later. Now, this isn't a story of multiple attendances to the GP where somebody had missed symptoms or opportunities. This wasn't a patient who knew her symptoms were not right and had tried to access primary care. This is more of a story about somebody who'd never had screening at all in her life. She was 32, so she'd had the availability of it, but had never attended. And she hadn't had the HPV vaccine. So this is a story of somebody whose odds were significantly stacked against her right from the beginning. And so when we talk about the aim of eradicating cervical cancer by 2040, which was name-checked a number of times in the NHS long-term plan, it's really important that we, yes, believe it to be possible, because it is, but we've got to make sure that there is that we think about the cohort of people that we are not reaching, and we've spoken about this on a number of occasions. I just want to briefly talk us through the science and the sort of the more national strategy behind cervical cancer. One of the biggest things that has impacted the course of cervical cancer has been the knowledge that there's such a strong association between the human papillomavirus and cervical cancer, and in particular 2 specific strains of HPV. There are others, but 2 strains up there, 16 and 18, account for about 80% of cervical cancers. We know that HPV is a very common infection. So anybody that's sexually active throughout your life, you're likely to come into contact with it. About 80% of us will come into contact with it. And most of us will deal with HPV effectively, easily, and our bodies will remove it effectively. But there are some women where the infection becomes more persistent. And if it's one of these more cancerous causing strains, that is where the problem comes. Since 2008, there has been a vaccination programme for HPV. Started off just being offered to girls and now is offered to both boys and girls. And so every school-age child in year 8, so between 12 and 13, will receive at least one HPV vaccine. And that's incredible. What it probably wouldn't have helped, though, was my patient Gemma. Based on her schooling history, she would be the type of person who may not have had that. We do have catch-up campaigns. Again, we've spoken about it before. And in the long-term plan, there was mention of maybe expanding the catch-up programme to include a commissioned service through pharmacy. But the key questions remain. We need to understand who the people are that we're not reaching, and we need to have effective ways of engaging with them. The other thing that we'll all be familiar with will be the cervical screening programme, which has been around for much longer, but has also adapted to the increasing knowledge that we've got around HPV. It's still fundamentally a nationally invited scheme, although it is one of the functions that is going to be devolved to ICBs at some point in the future. So some of the actual logistics of this might well change. And women now, when they attend, often it is delivered in primary care. The screening approach involves a two-phase approach. It still involves quite an invasive investigation and examination. And then the cells that are sampled will initially have an HPV test done, and it would only be in the case of an HPV positive that the cells that are sampled will then go and have cytology. The thing that I'm sure most people in the room will be aware of is that on the 1st of July, the presence of HPV, particularly if it's negative, has changed the screening interval for women of all ages now. It used to be that younger women would have a 3-year interval, but it's now, since the 1st of July, a 5-year interval for women that on the cervical sample have an HPV negative test. How effective is it? I think we've seen a lot of stats today, and I think the biggest thing that I'd want people to take away from this slide is that despite an aim of 80% of eligible women going through the cervical screening programme successfully, we currently hit about 68%. But the biggest thing here is the inequity of access. I've put some stats on there around various groups of people who are underrepresented when it comes to cervical screening. It might be ethnicity, it might be sexual orientation, it might be people suffering with severe mental illness or learning disability. And there's lots of other women who don't fit into these categories, who may have been victims of violence, rape, all sorts of things that have a massive impact upon whether they're going to attend for what is a very invasive test. And there's some knock-on effects to that. So we've got inequity of access, we've got inequity of outcome, and we've also got some workload that comes from people that don't attend for their cervical screening. And often that workload lands on the door of primary care. So often it's our teams that will have to both be aware of which patients have not had their cervical screening done. We need to make sure that we're inviting them, we're encouraging them, we're speaking to them, we're trying to get them engaged to have their cervical screening undertaken. And we need to code these things, because if we don't, then there are some financial impacts for us. We've got QOF targets to reach with cervical screening, which can unfortunately disadvantage practices who have populations in more deprived areas. We've also got primary care network DES, which makes screening and health inequity are a really key part of what it's trying to ask primary care networks to do. So there's lots and lots and lots of work that goes on in primary care to try and deal with this. So on a national level, you may have seen or you may be aware of a new approach that is being championed and is going to be rolled out, and that is self-swabbing. So rather than a woman having a rather invasive examination by a primary care clinician, for women who don't respond to their initial cervical smear invitation, there is a push for that woman to be offered a self-swab. Much less invasive, can be done in the privacy of their own home, can be done in a clinical setting, because I think opportunistic sort of discussion with a woman is likely to be really important with this. The evidence behind why this has been recommended is on the screen behind me, but I just want to make a few really key points. The UScreen trial, which is the one on the left-hand side of the page, was looking at a group of women in London, and it was when women had been 15 months overdue their cervical sample. They were offered either by mail out or when they saw their GP, they were encouraged to have a self-swab taken. And what the key sort of points that I'd want to make from this are that about 65% of women who were offered this returned the kit. So this is women who probably at 15 months post cervical invitation would not have attended that appointment. So that's 65% of that cohort did feel that a self-swab was a good thing and that they went ahead and gave it. The other, and this is really important, when or if the HPV self-swab came back showing the presence of HPV, they then did feel activated to go ahead and have the cervical sample taken so that the cells could be looked at from a cytology perspective. So the follow-up from a positive HPV test was about 85%. That's really, really, really encouraging. On the right-hand side of the screen is the HPV Validate trial. In this trial, they looked for two things. They looked at how effective was the self-swabbing. So were the self-swabs that were available, and with the lab availability to test those swabs, how accurate was it? Could it detect HPV effectively? And it was there's 4 combinations that came out really, really well on that. And the other thing, and again, this is really important when we think about inequity and accessing this type of service. 98% of women said that they thought it was good or excellent. So really, really, really high levels of acceptability. And that is something that probably, if we look at the more traditional cervical screening approach, the acceptability component of that is perhaps not as high as we maybe need it to be. So what does that mean? Well, the details of how this is going to work are still not entirely clear. There's still going to need to be an awareness of which patients and which women are suitable and are eligible for this service. So there's always going to be a need to identify the correct cohort of people. There's also going to need to be work in reaching out and engaging with women. We've had some really interesting approaches that we've heard today about how we can reach out to people and how we can engage people and how we can encourage them to sort of partake, whether it's in screening or whether it's in a diagnostic test. And we need to draw upon all of that experience and all of that skill into this component. There's also the fact that there is a logistical component to this. Somebody's going to have to get a self-swab to a patient, to a woman. Somebody's got to then analyse the results of it, and those results have got to be followed up. It's highly, highly likely that a big proportion of this work is going to come to primary care in some capacity. And so it's really important that that we're aware of it and that we're part of the process of making this a reality. So how can digital solutions and how can we help with this? We've heard sort of case finding used quite a lot. There is no doubt that the ability to identify the correct group of people is going to be incredibly important here. The primary care healthcare record is a wealth of information. We tend to code when we invite people, when people attend for smears. We have a lot of information available to us, which will make primary care a good place to support this. Personalised communication is going to be critical here. Digital solutions offer the opportunity for us to present information in different languages, in different ways, with different media attached to them, whether it's video, animation. There's all sorts of opportunities for us to really try and send a message to people. There will always be a need, though, for working with your local populations, because when it comes to reaching communities that have been underrepresented, often, and I think back to what happened with my case, it was actually after the event, it was somebody from that Roma community who became activated, engaged, worried, wanting to do something, and it was actually them being able to communicate a message to their Roma community, which was incredibly useful and managed to activate people into coming and having cervical screening done in a way that in a way that hadn't happened before. So I don't want to come across and say that digital is the only way. Digital is part of the way, and that's why working with all the various different pieces is key. Moving to action. So I think there's likely to be a scenario here where we're going to need to enable a woman to quickly and efficiently determine which way they want to go. So, for example, once they've got an intention to do something, we need to make it easy for that to happen. And the coordination piece right at the end, which is where we're going to have to work with UCSA, national screening, ICBs, your local populations, primary care, trying to coordinate all of that and provide a visualisation of where a patient is along this journey is going to be a really, really, really key and important part. And when we speak about dashboards and when we speak about provider dashboards, a lot of this is about showing where a patient is in a particular part of a care journey. And I think if we can identify the correct people, reach the right people, we're going to make some marginal gains. So I'm going to use the term that Chris Hoy used earlier. It's about making marginal gains here towards a scenario where people that are massively underrepresented at the moment do get access to the care that they deserve and need. So that's the end of my presentation. My details are on there. We genuinely, anybody that's working in trying to sort of minimise and reach people suffering with health inequality, love to hear about the type of work that you're doing. We'd also love to hear from people, particularly around cervical screening, if this is something that's tweaked your interest and you're thinking of developing pathways and approaches to try and manage this workload, and then do reach out to us. And thank you very much for your time.
I think we're running a bit late, but we've got time, I think, for one or two questions. James, I think we've got a lady there.
Looking at that pathway, personalised information, and then patient has to make a choice, ask for a swab test or ask for a smear test. We're making it opt-in. For bowel screening, it's opt-out. Is there a reason?
I mean, I think a lot of this is to do with the detail of the actual approach and process are not quite known yet. I suspect that what will happen is I think what the study showed was that opportunistic, so somebody coming in to see you in general practice, that was probably the most effective way of actually supporting a woman to have a self-swab. But there's no doubt that when you've got a population that you know of and that you can hopefully have details of to reach, then I suspect that it will fundamentally be sort of rolled out in the way that you've described.
Great. Any other questions from the audience? Oh, we've got one in the corner.
Will women be able to choose that they want a swab and not a smear? Because to have a smear, I know, is not a piece of cake.
Yeah. So at the moment, the approach that is being spoken about is that the traditional cervical screening programme through attendance and having the more invasive test is going to be plan A, and then the self-swab will be offered to women should they not respond to that. The evidence is strong at the moment for how effective the self-swab is, at least in detecting the HPV component of the pathway. So I suspect it will be one of those things that will evolve, but clearly that's something that sort of the national teams will be making judgments on. But I think it's a very fair point.
Yes, because some women could feel discriminated because they had been having their smear test, and I don't know.
Yeah, I don't think there's any woman in this audience who's going to disagree with that. I think Professor Sir Mike Richards wants to weigh in.
Oh dear.
Well, I felt I better weigh in as I chair the group that actually makes the recommendations. And absolutely, as you've said, for those who are, the term we're now using is underscreened. The people who are underscreened, the evidence from the U-screen trial is compelling that amongst those people, we do get the numbers that you've just shown, and so that's going to be a benefit. There is still uncertainty about whether it would be better, first off, that there are slight concerns about is it quite as accurate as doing the traditional cervical sample. That's being investigated now. Whether in X years' time we will still be doing the old-fashioned way, I somewhat doubt, but I have to wait for the evidence.
Yeah, quite right too.
Perfect. Well, thank you, John.
Thank you. Thank you, everybody.